Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and this is going to be the first in our medical, surgical, med-surg, or adult health lecture series for nursing school. This first lecture of respiratory diseases is going to go through respiratory system. We're going to talk about a lot of different components of the respiratory system. Now, this is meant to prepare you for your RN nursing courses in respiratory or pulmonology. This is not going to teach you everything that you need to know for respiratory or pulmonology. However, it's certainly going to give you a very strong foundation, and it's probably going to cover more than half of what you're going to learn in nursing school in terms of the respiratory or pulmonary systems. So let's go ahead and start with a basic anatomy and physiology review. The primary function of the lungs is to inhale oxygen and exhale carbon dioxide. Now, there are four types of hypoxia, which sort of relate to the four ways that this can go wrong, that this system of bringing air into the body in order for us to get oxygen out of it and to put carbon dioxide into it and blow that out, four ways this can go wrong. Now, I'm right away going to tell you this is probably beyond what you're going to see in RN school. I didn't see this in the nursing med-surg books that I looked at, but this is something that's very foundational, which is going to help you for the whole rest of this video. So really quick, the first type is hypoxic hypoxia. This is where you're simply not getting enough oxygen in the air you breathe. So this can be from high altitudes. This could be because you're not breathing well enough because of decreased respirations, let's say from an opioid overdose, because you have a lung disease, something like that. So hypoxic hypoxia is you're not getting enough oxygen. Anemic hypoxia is you are getting enough oxygen, but you're anemic. So your ability to carry that oxygen to the cells is affected. Next is stagnant hypoxia. Again, you're getting enough oxygen and you're not anemic, but the blood's not flowing well. If the blood's not flowing, if let's say you're in shock or heart failure, if the blood's not flowing, then the oxygen's not getting delivered to the cell. And finally, the fourth one is histotoxic hypoxia. This is where the cells are unable to use the oxygen despite delivery, such as with cyanide poisoning. Let's go through a few more A&P review. First of all, the secondary function of the lungs is to maintain acid-base balance. There's three components of maintaining our acid-base balance. The respiratory system and the kidney systems are the two primary components. The kidneys are the main one, and the lungs are secondary. The next one is going to be let's go over the anatomy. So the upper airway is going to be your mouth, your nose, your sinus, your epiglottis, and your larynx. The lower airway is going to be your trachea, your bronchi, your bronchioles, and your alveoli. The lungs are composed of 5 lobes, 3 on the right, 2 on the left. The reason we have 2 on the left is because where the third one would be is where our heart is. Next, let's talk about the pleura, because this is the first place students start to get confused. We have the visceral pleura and the parietal pleura. These are next to each other. They rub against each other. The space in between these is what collapses and expands as the lungs inflate. So when the lungs inflate, these are right up next to each other. When the lungs deflate, when the lungs are really uptight, these two are not touching each other. When the lungs expand, now these two are up against each other. So the visceral pleura lines the outside of the lungs. The parietal pleura lines the outside of the thoracic cavity. So again, when the lung expands, now it's up against it. When the lung contracts, now there's an open space over there. Pleural fluid is what lubricates this area in order to allow them to keep constantly moving against each other, because every time the lungs expand and collapse, these move against each other. There's a pleural fluid there that prevents friction and provides lubrication. Our control of breathing is regulated in a healthy patient by the brainstem based on CO2 levels, meaning we said the two primary functions of the lungs are to exhale carbon dioxide and inhale oxygen, and regulation can be based off either one. We can either breathe when we have low oxygen, or we can breathe when we have high CO2. In a healthy patient, normal physiology is we breathe when we have a high CO2. So when you're able to hold your breath, let's say swimming underwater, how long can you hold your breath? As long as the CO2 level doesn't get too high. Once it gets too high, the body's going to force you to breathe. Now, there is something called hypoxic drive. We'll talk about this more at the end of the lecture when we get up to the diseases and we talk about COPD. But for right now, hypoxic drive, very simply, is where we switch to the other mechanism. We said normal physiology is we breathe based on when a CO2 level is high. Hypoxic drive is we breathe based on an O2 level being low. And we'll talk about why that is that case in certain patients. Next, let's do a definition. Ventilation is breathing. It's moving air in and out of our lungs. This should not be confused with oxygenation. Oxygenation is the process of oxygenating the air. So if I put a patient on non-breather mask over them, I'm oxygenating the air that they are breathing, but I'm not ventilating them. When I squeeze a bag valve mask, now I'm ventilating them. I'm moving air in and out of their body. The primary muscle of ventilation is the diaphragm. However, we do have accessory muscles, such as the muscles in between each rib. Next, let's move on to our respiratory assessment. First, we start with work of breathing. All of us are breathing right now, And that should be a benign process. It should be something that we don't even think about, we don't recognize is even happening. However, when we notice someone's actually working on breathing, immediately we should recognize that's a problem. When we're assessing the WOB, the work of breathing, that's where we assess the effort that they're putting into it. Are they focused on it? Are they straining to do it? Are their nostrils flaring, trying to bring in more oxygen? Are their muscles between each rib expanding and collapsing, trying to breathe in more oxygen? Are they putting work into their breathing? Next, we have lung sounds. Normal lung sounds, you should already know that. That's going to be what's expected to hear in a patient. Stridor is a sign of upper airway obstruction. Stridor is an upper airway obstruction. Wheezing is a lower airway obstruction. Rhonchi can be a number of different things. I'm going to let your nursing school go into exactly what they want to teach about that. Rales or crackles is fluid in the lungs. So just like you can imagine, when you take a straw and you put in a cup of water and you blow into it, when we breathe into our lungs, if our lungs are full of fluid, it's exactly the straw in the cup of water blowing bubbles. That's what rales and crackles sounds like. Diminished is where you don't hear a full, loud, good breath sound when you listen. It's where you hear a very quiet sound, showing that they're not moving a lot of air, that there's not a lot of lung expansion. And finally, absent breath sounds can be that the patient's not breathing, or if, let's say, I just listen over one spot, maybe this lung collapsed, and that's why I don't hear any breathing over there. Chest rise should be symmetrical, meaning both sides of the chest should rise and fall together. We should be assessing the depth of inspiration. Are they taking really small, shallow breaths, or are they taking normal, healthy breaths? Hopefully you remember from your CPR course that you took that when we squeeze the bag valve mask, we are just squeezing it just enough to see chest rise. We're not just squeezing it, trying to pop their lungs. And again, we're going to look for accessory muscle use, which would be abnormal finding. Let's go through some definitions. We have normal breathing, which is eupnea, and we don't really use that word, but I just threw it on there. Next, we have the abnormal breathing. Apnea is where a patient is not breathing. Bradypnea is where a patient's breathing slowly. Tachypnea is where they're breathing very quickly. Dyspnea is where they have difficulty breathing. Orthopnea is where they have difficulty breathing while lying flat. Agonal breathing is where they're gasping or ineffective respirations. Almost always when you hear the term agonal breathing, that's going to be the last few breaths someone takes before they die. Cusimal respirations or cusimal breathing is deep labored breathing. And this is where patients moving a ton of air in and out of their lungs. And in that case, you'll learn more about this in endocrine, but that's where the patient is trying to actually blow off a lot of excess CO2. That's a side effect of metabolic acidosis. Cheyne-Stokes respirations is a cyclical pattern of apnea and hyperventilation. So they'll go no breathing, then a lot of breathing, then no breathing, and it goes in a pattern. Biats or Biats respirations are irregular respirations where the patient has periods of not breathing and then goes into some abnormal pattern. You'll learn more about each of these with different diseases of which can cause which. Next, when we have features of breathing, that's going to be tripod breathing. Tripod breathing is where a patient leans forward, puts their hands on their knees, and that's a sign of respiratory distress. Why? Because when you do that, you're taking weight off of your chest, especially if the patient is a larger build and they have a lot of excess adipose, that they're overweight, then they can have a lot of weight on their chest. So if they lean forward, it takes that weight off. It helps them expand their chest more to breathe. Again, that's a sign of respiratory distress. Pursed lip breathing is where a patient takes a breath in and then sort of blows out as if they were trying to blow out a candle. But when they do that, they're forcing the air to stay in their lungs longer, and that is going to help keep the lungs inflated for longer. It's actually going to help what's called PEEP, P-E-E-P, positive end expiratory pressure. That's something you definitely need to know that I'm not going to go too into in this video, but we'll mention it again in about 10 minutes. But this is going to help a patient develop PEEP, which is where we keep the lungs, the alveoli, inflated with air for a longer period of time, which helps oxygenation. And obviously cyanosis, I'm sure you already know this one. Cyanosis is where a patient has where their lips and stuff starts to turn blue. Next, we have pulse oximetry. Pulse oximetry indicates the percentage of hemoglobin molecules bound with oxygen. So every hemoglobin molecule should be carrying oxygen on board. And if they're empty, if they're not carrying oxygen on board, that's a problem. So when we measure it, the pulse oximeter is going to look at every hemoglobin molecule that goes past the diode, past the sensor, and it's going to see, is this one full of oxygen or is this one not full? If one goes by full, one goes by empty, your pulse ox will be 50%. If only one goes by and it's 100% full, your pulse ox will be 100. If only one goes by and it's empty, your pulse ox will be 0. That gives you an idea. We talk more about this in our vital signs video. Next, when we assess a patient for a cough, we're always going to assess productive versus non-productive, meaning is it a dry cough or are they actually coughing something up? And just to throw in a definition here, hemoptysis is where they're coughing up blood. As a nurse, when you're charting a productive cough, you're going to ask the patient to describe the sputum, or if you got to examine it yourself, you would detail it. Next, let's go through some pulmonary diagnostics. We start with a PFT, a pulmonary function test. This assesses the lungs mechanics. It includes airflow, lung volume, gas exchange, how much air can the patient's lungs hold, how well are they exchanging air. Usually we'll do this test and then we'll give them a bronchodilator, which is albuterol, and then we'll repeat the test and see the difference there. This is used for the diagnosis of asthma and COPD, and this is a very foundational test in dealing with pulmonary assessments. Next, we have sputum cultures. These are best collected in the morning before eating or drinking so that we get one that's, not to sound awful, but one that's really rich with bacteria. When we do this, we have the patient rinse their mouth out to avoid contamination from the oral flora. So again, we're trying to collect it from the sputum, from what's in the lungs, not what's in the mouth. So we want the patient to rinse their mouth and then go ahead and give us some sputum from the lungs when they cough it up, so that it's actually coming from the lungs and it's not affected by what's in the mouth. When we're told to collect the sputum culture, if we're also told to start antibiotics at the same time, we're always going to collect cultures first. Finally, we would use a sputum culture for identifying the exact specific pathogen that is making a patient sick so that we can target the correct antibiotics. And that's called culture and sensitivity testing, which is also discussed in the infectious disease lecture. Next, we have a chest x-ray. Chest x-rays are very common. They're basically a dime a dozen. They cost about, I don't know, here in Vegas, they're about $25 for a self-pay patient. So they're really cheap. They're really commonly used. They are used to diagnose pneumonia, tuberculosis, pneumothorax, pleural effusion, so much more. And they're also used very often to rule out other conditions like a pneumothorax and things like that. So we do these on any patient that has a respiratory and almost any patient that has a cardiac issue. There's different views, and I don't know how detailed your school is going to get into this, but there's AP, PA, and lateral. AP is anterior, posterior, meaning you're taking it from the front and it's shooting towards the back. PA is the opposite. And lateral is where they're shooting the image from the side. Lateral means the side. When you are a nurse taking care of a patient that's getting a chest x-ray, make sure you remove their metal objects from their chest area or whatever area is getting imaged for that matter, including jewelry, necklaces. If you have ECG stickers on them, those always have metal, almost always have metal in them. So make sure and remove those as well. Next, let's talk about a chest CT or chest CAT scan. CT is a CAT scan. This provides detailed cross-sectional imaging that's useful for identifying cancer, pulmonary embolisms, tons of different lung pathologies. We use this all the time. There is another type of a chest CT. It's called a spiral CT. This one is often used for things like a pulmonary embolism, where we're looking for a blood clot. And then obviously a chest CT can be gotten with or without contrast, depending what we're looking for. And that's a little bit beyond what we need to know as an RN. When you're sending a patient for a chest CT, this is where they go into the machine. It's pretty quick. They're in and out. They don't put them to sleep or anything like that. If they don't need contrast, then they don't need an IV. There is also oral contrast available depending what the provider has ordered. Next, we have a D-dimer. A D-dimer is a blood test that's used to detect indications of clot formation. It looks for tiny little fragments that are associated with clots. And when we see that a D-dimer is high, that tells us there's a chance the patient's having a clot. When we see that it's low, it tells us that's pretty unlikely that the patient's having a clot. It doesn't really diagnose. It sort of more helps us rule out. So if we see a D-dimer is negative, we may feel more comfortable saying you're not having a clot. If we see it's positive, we're still going to do follow-up testing. And the follow-up testing, as we just mentioned, if it's in the chest CT, it might be a chest CT if we're worried about a PE or something like that. Next, we have a gophony. Gophony is really not used a whole lot, but it is absolutely still taught in nursing school. This is an oscillatory exam, meaning it's listening to the patient's chest cavity with a stethoscope when they say the word E. And we're looking to hear if that E sounds like an A. If it sounds like an A through the stethoscope when you're listening to a certain part of the lungs, that suggests consolidation, which we'll learn in a few minutes is a sign of pneumonia. But that's what a gophony is. Not very much used, but it's still fair game for your tests. Next, we have an ABG. I want to preface this by saying ABG is a whole lecture in itself. I'm just giving you the highlights here. So ABG measures your oxygen level, your PaCO2, which is your carbon dioxide level, your pH, your bicarbonate of the arterial blood. Because whenever we do a regular blood draw for typical labs, when you go to some local lab to get your annual blood work, that's all venous blood. This is arterial blood. So again, there's a whole lot more to know about this and interpreting this, and this gets into how we diagnose metabolic acidosis and respiratory acidosis. That's a whole separate lecture, so I'm just going to keep it to the basics right now. There is something called the Allen test, which I've seen so many times in nursing exams, so I do want to specifically mention that here. An Allen test is where we check for the patient having collateral circulation. So when we check an ABG, we're almost always using the artery over here to draw blood. Now, this artery supplies blood to the hand, and this artery supplies blood to the hand. An Allen test is where before we poke this one, we make sure that this one has good perfusion, because otherwise, if we touch this one and we mess it up with our test, the patient doesn't have this, they have no more circulation to their hand. So it's relatively uncommon. It's still the standard of care that we do the Allen test. I've never had an Allen test come up with showing me a problem, but it's certainly something that you would be expected to be knowledgeable of as an RN. Granted, RNs don't generally do ABGs, but there are certain settings and units where you may be doing them. And like I already mentioned, the ABG is used to assess respiratory function. It checks your O2, your CO2, your bicarb, and it also is foundational, assessing your acid-base balance, such as metabolic acidosis and alkalosis, and respiratory acidosis and alkalosis. Moving on, we have bronchoscopy. This is where they do direct visualization of the bronchi. They put a flexible tube down into the bronchi to see exactly what's going on. Obviously, the patient can't have a gag reflex for this, so this is done under sedation in most cases. And in this case, we can actually pull out some specimens with that tube that we put down that has a camera that we're looking at. We can actually, it can have grippers on it that we can use to even cut a piece off of the lungs if we see something that we want to pull out and biopsy, but mostly we use it for direct visualization for diagnostic purposes. Next, we have thoracentesis. Thoracentesis also could probably be its own lecture, but thoracentesis involves the insertion of a needle into the pleural space. Remember, that's the space in between the chest wall and the edge of the lungs. That's what expands every time the patient's lungs exhales. When the lungs are collapsed, when they are not bleeding, when they're exhaling, the lungs collapse up, and now there's a big gap between the wall and the lung, versus when the lung expands, that gap closes. Now, thoracentesis involves insertion of a needle into that pleural space to remove fluid. This could be therapeutic if the patient has fluid built up in there. We're going to talk about that in a few minutes. Or it could be diagnostic, where we just want to get a sample of that fluid and get it tested to figure out what's going on. Usually this is done under anesthesia, local anesthesia. We just numb the area and we use an ultrasound to show us exactly where to poke. A few last notes, and then we're going to go into all the different pulmonary diseases. Head of bed, or HOB, is a common terminology in respiratory patients, and this is where we have the patient's bed, instead of being flat, we could have it 30 degrees, 45 degrees. I'm not doing it very well, but 90 degrees, etc. Head of bed is where we elevate the head of the bed in a respiratory patient. And for nursing exams, you're often going to see what would be an appropriate intervention for a patient in respiratory distress, and it's to say elevate the head of the bed. Rhinorrhea is just a medical term for a runny nose. Just thought that's something you should know. Pleurisy is inflammation of the pleuras that we talked about a few times now, the visceral and parietal pleura. When they're inflamed, that can cause sharp chest pain. And as you can imagine, every time they breathe, when they inhale and those two are rubbing against each other, that's when it hurts, and it can result in coughing as well, but really sharp chest pain every time they breathe in. And that's an inflammatory problem. That's usually a symptom, not a diagnosis, which is why I have it up here, not at the bottom, when we get into all the diagnoses. Incentive spirometry, also known as IS. This is a device that's designed to encourage deep breathing. You can Google it real quick, 100 images will pop up. Usually it has two little handles and a tube and a spout for you to breathe into it. This is designed to encourage deep breathing. We have the patient hold it and breathe into it, and we set a goal for them for how high they should get that meter when they breathe. It improves their lung expansion, and the more a patient uses their lungs, especially when they're sick, the more they could beat an infection, not really beat it, but the more they can get rid of an infection by recruiting every bit of those lungs for oxygenation, can also increase the patient's oxygen level. So there's a lot of benefits to it. There's a lot of benefits to incentive spirometry, and you're going to see this as a non-pharmacological intervention in a lot of different diseases that you're going to learn in the respiratory system. Oxygen is a whole discussion by itself. That is a prescription medication. We do discuss it extensively. I have a whole separate video that's posted under fundamentals just about oxygen. Next, we have mechanical ventilation. So mechanical ventilation is something that, depending how your nursing program is set up, you may get into it really detailed over here, or you may have a separate critical care nursing class, in which case that's where that would be covered. I did cover it briefly over here, but really it's a whole separate class. Mechanical ventilation is where we put the patient on a ventilator and we take over their breathing, or we support their breathing, assist their breathing. There's a lot of options we have in how we manipulate their breathing once we take over breathing for them. Now, I just want to clarify a few points. When we mechanically ventilate a patient, whether it's with a BVM or we hook them up on a ventilator, in either of these cases, this is called positive pressure ventilation, because a patient's normal breathing, what me and you are doing right now, is called negative pressure ventilation. Now, let's go through some more things. Positive pressure ventilation is where we're breathing for them on a ventilator or a BVM, a bag valve mask, like you learned in the CPR course. Then we also have non-invasive positive pressure ventilation. This could be CPAP or BiPAP. CPAP is where the patient's getting a constant stream of air in their face, and that is going to help keep the airways open and keep them getting well oxygenated. BiPAP is where it does intermittently. It gives them a thrust of air and then it holds back, gives them a thrust of air, holds back. It's more intrinsic, allowing them to actually exhale, because in CPAP, they're actually exhaling straight into a flow of air. It's not as bad as it sounds, but these are the two different mechanisms that we use. There's a ton that goes into when we choose CPAP over BiPAP. That being said, there's sometimes we trial one, we trial the other. All of that is beyond what most RN schools would get into. If your school wants to get into, I'll let them do that. Let's go through some more terminology related to mechanical ventilation. We have weaning, which is where we slowly take a patient off their ventilator and allow them to slowly start breathing. Remember, this is complicated because a patient's been breathing on their own since the second they were born, literally. And all of a sudden, for whatever reason, trauma, surgery, whatever, we made them stop breathing and we started breathing for them. That gets a little bit dicey. So when we need them to start breathing on their own again, we need them to do it gradually. And so we need to still support them as they're coming back into breathing on their own. Sort of like if you're familiar with pharmacology, when we taper a medication, we'll slowly take a patient off. It's the same concept here. A few more things to know about. There's something called VAP, ventilator-associated pneumonia. This is where a patient develops pneumonia once they've been intubated for more than 48 hours, and we'll talk about that in a few minutes when we get to pneumonia. Barotrauma is a huge issue nowadays in terms of mechanical ventilation. It's a complication. It's where the patient's lungs gets injured, because remember, when we breathe, I can inhale pretty much as much as I want. I'm not going to pop my lungs, versus when I am putting air into the patient through a mechanical ventilator and I'm adjusting all those settings to determine how much air I want to put in, there I can easily overshoot my numbers and pop their lung and cause some major issues. So that's called barotrauma. It's injury to lung trauma caused by excessive pressure during mechanical ventilation. Next, we have chest tubes. Chest tubes, again, sorry to say this, the last time I'm going to say it, is a whole separate lecture by itself. I'm going through some of the highlights here, but again, in most nursing schools, this will probably be taught in either a skills class or a critical care class, but I am going to go through it relatively quickly here in the respiratory lecture. So chest tubes drain air, blood, or fluid from the pleural space. Again, that pleural space is that space in the lungs that is empty when the patient is exhaling, and it's full when the patient is fully breathing in air. So if there's a collection of air in that space, or blood or fluid, the lung can no longer fully inflate with air, which becomes a problem. So we do have chest tubes that can drain out air, blood, or fluid from that space and restore the ability for the lung to fully expand. The definition for these, by the way, when it's full of air, it's called a pneumothorax. When it's full of blood, it's called a hemothorax. We're going to talk about both those in a few minutes. And when it's when it's fluid, that would be an infection, and we'll talk about that as well. So this is used for a hemothorax, a pneumothorax, to drain out that blood, to drain out that air, as well as post-operative drainage. So if a patient had surgery and there's going to be some leakage of fluid at the surgical site, and the surgical site is in the chest, we would put a chest tube in there as well to drain that fluid out, and also for effusions, which is a buildup of fluid. When you're dealing with the chest tube, there's a whole ton to know about the drainage systems, and there's a few different drainage systems. There's water drainage systems, etc. Make sure that the drainage system's at the chest level to prevent backflow. That's a common nursing school test question, so I just want to throw that in there. Any patient who has a chest tube is always going to be encouraged to do deep breathing and coughing and ambulation. I shouldn't say always, because there's definitely exceptions, but is encouraged, as a nurse, that you should be encouraging them to do deep breathing, coughing, and moving around to help the patient get better, no matter what the path was of that got them into the situation of needing a chest tube. There are a bunch of complications. Most commonly is going to be an ear leak or infection or the tube coming out. All of those are things you would have to monitor for as an RN. Now, before we get into the very next sections, all the different respiratory diseases, I just want to point out, for most of these, especially your upper respiratory infection, your pneumonia, your flu, we're always going to encourage rest, fluids, and preventing disease transmission, which means as a nurse, you're going to advocate for them getting a doctor's note if that's appropriate, so that they don't have to go and infect others. You're going to recommend that they get that time off so that they can rest, and that they should take fluids. Now let's go through all the different diseases, and for each one of these, we're going to go through multiple aspects of it. We're going to start with a rib fracture. For this one, I don't really have much. A rib fracture, you know what that is. It's a broken bone. Which bone? One of the ribs. That's what a rib fracture is. Now let's talk about flail chest, which is a complication of a rib fracture. So flail chest is multiple rib fractures in one area. So if you have one area of lungs right over here that, let's say, ribs 2, 3, 4, 5 all broke right over here, and then they all broke again right over here, now I just have a section of ribs that are disconnected from the rest of the rib cage. That becomes a free-floating section, and that is a flail chest. It's relatively uncommon. It's almost only seen in major chest trauma. And that can become a major issue because now you have a part of the chest that's moving independently of the rest of the chest. So that's what a flail chest is. It's multiple rib fractures. By definition, it's multiple rib fractures where the bones are broken, two or more bones are broken in two or more places, creating an independent section of ribs. You don't need to really know that definition, just understand the concept. So how would this present? Paradoxical chest motion. When the whole chest is expanding one way, this might be doing something else. Obviously, it's going to have respiratory distress because they just had major chest trauma. It can have cyanosis because chest trauma can impair O2. It can have crepitus, which is the sounds of two bones rubbing against each other. That's definitely part of the patho of this. And obviously chest pain because that's pretty painful in their chest. Next, how is this diagnosed? Usually a chest x-ray can tell us this, or we can use a chest CT. You're going to see pretty commonly that it's going to be a chest x-ray or chest CT. And in most cases, we're going to do the chest x-ray. And if that's normal, we're good. But if we find something on there, we're going to follow up with a chest CT. How do we manage this? It's a broken bone. So we have to do a few different things. First of all, we're going to give them oxygen in case it's affecting their oxygenation. We're going to manage their pain because keep in mind, it may be so painful to them that they sort of stop breathing in a way, or they really limit their breathing because they don't want that pain that comes with every breath of the bones rubbing against each other when there's chest movement. So we definitely have to control their pain. They may need to get put on a mechanical ventilator. They may need surgical stabilization in order to repair those ribs or at least wire them together so that they're no longer free floating. And it may, in the short term, also need some sort of stabilization on that area, maybe with a, I'm not going to get into it, but there's different methods to do that. Next disease we're going to talk about is pulmonary contusion. Pulmonary contusion is where the lung tissue bruising causes alveolar bleeding and edema. What does that mean? That means that there's damage to the lungs, and now the blood vessels in the lungs are causing some bleeding and some swelling. So there's some bleeding and swelling going on in the lungs. This is relatively common in chest trauma, and doesn't even take major chest trauma to get this. In most cases, this is not something that needs a specific repair. This is something that in most cases, if it's mild, if a patient has a mild pulmonary contusion, it heals on its own. How does it present? Hypoxia, because obviously anything to do with the lungs is going to have that hypoxia and dyspnea. Hemoptysis, which is coughing up blood because we just said it's blood vessels being popped in the lungs. And it can cause worsening bleeding over the next 24 to 48 hours. In most cases, especially the more mild cases, after that, it would start to improve on its own. This is diagnosed with a chest x-ray where we see a little bit of blood in places where we shouldn't, and we would follow up with a chest CT. How do we manage this? We ensure that they don't become hypoxic by giving them oxygen. We give them pain relief if needed, and we simply monitor for complications like ARDS, which can develop from this, and we'll talk about it in a few minutes. Next, we have a pneumothorax or a hemothorax. The patho is, we already discussed, air or blood collecting the pleural space, meaning that the lungs can no longer fully inflate or expand like they're supposed to because there's air or blood blocking them. The presentation is going to be that that part of the lungs, if let's say it's right over here, this part of the lungs will have diminished or absent lung sounds. It can also prevent with tachypnea, which is fast breathing, because the patient can't breathe as deeply to get air into their body, so they're breathing quicker to make up for that loss. This is diagnosed with a chest x-ray and a follow-up chest CT. And how is this managed? With oxygen, with pain relief, like we already said. Or I'm sorry, I'm looking in the wrong place. This is, it's managed with correcting that issue of there being air or blood in the pleural space. And we already mentioned a few minutes ago, this would be treated with a chest tube to get that air out. And in the emergency setting, we may even just literally pop a hole in the lung to allow the air to come out or the blood to leak out. We could do this with our finger. We could do it with a needle decompression. Those are two things you should just know are associated with the emergent decompression of a pneumothorax. But generally speaking, in most exams, the answer here is going to be a chest tube. The chest hole that is made from either a chest hole that is either a result of trauma or placing a chest tube must always be sealed with an airtight dressing. Otherwise, we're going to make the problem worse. So if a patient does have a chest tube that was put in, let's say it's usually on the side of the ribs, when we the doctor sutures that into place, we do need to put a airtight dressing on that in order to prevent any more air from getting in there and causing different problems. A pneumothorax can result spontaneously, in which case these are usually slowly developing, and they may not, and sometimes they're even just monitored. We don't even treat it right away, but it could be spontaneous, but much more commonly it's a result of trauma. A tension pneumothorax is where there is air building up in one area of the lungs, let's say right here, and that area of dead space is expanding and expanding, and now the lungs, not only they can't inflate, but it's actually starting to push the lungs away, that whole area is now shut off for the lungs to use. And as that area expands, it can actually start to squish the lungs. It can start to squish the heart. It can cause massive problems. It can cause death. So that is an accumulation of pressure on the heart or the unaffected lung. A hemothorax is when blood fills up the pleural space. We've been talking about pneumo, but I'm putting them the two together. This can occur with or without a pneumo. That would be called a hemopneumothorax. And blood is always drained out with the chest tube, as opposed to ear can be sometimes just poke a hole and let the air leak out and then seal it, and that problem solved, versus hemothorax, poking a hole doesn't usually work. Almost always that needs a chest tube. Next, let's talk about asthma. Asthma is a ton to know about, and depending how deep your school wants to get into this, I covered most of the basics here, but there's always more room to go into this in depth. Asthma is a three-pronged problem. Problem number one is bronchoconstriction. The bronchi, the tubes that we use to pull air into our lungs, become smaller. They constrict. Next, they become inflamed. So not only do they become smaller, but the walls of the bronchi become thicker, which further narrows the diameter of the bronchi, making it even more difficult to move air in and out of those passages. Plus, it gets a buildup of secretions. A buildup of secretions like mucus. So now not only did the bronchi get smaller and inflamed, which made it even smaller, but now it's also full of crap in there. It's full of mucus and secretion. So that makes it really, really difficult to breathe. How does this present? Respiratory distress, hypoxia, tachypnea, and wheezing. You should remember that wheezing is a lower airway obstruction or lower narrowing of the lower airway vessels. So that's exactly what this would have. And tachypnea would be breathing quickly because they can barely pull any air in, so they're having to breathe quicker to make up for it. Hypoxia and respiratory distress, obviously, because they're having difficulty breathing. This is diagnosed in the short term and the long term. In the long term, this is diagnosed based on history, physical exam, and spirometry. In the acute setting, this would be diagnosed based on history and physical exam. We wouldn't do spirometry testing in the acute setting. I want to be very clear about that. That would be for the official diagnosis of asthma done in the state once the patient has been stabilized. The management of asthma is going to be give the patient oxygen, to give them bronchodilators like albuterol, which is also called a SABA, S-A-B-A, short-acting beta agonist. We would also give them very often something called Atrovent. Atrovent is an anticholinergic medication. It's also inhaled. It can also be mixed with the albuterol, again, to help expand their lungs. They can also get corticosteroids. This would be an injection or a pill to help reduce that inflammation. We would put them in a high Fowler's position. That's how we seat them up. Again, we talked about that earlier with the head of the bed. And we also, very, very importantly, in any patient that's an asthmatic, we try to reduce their stress and their triggers, because most asthma is trigger or stress induced. Next, I want to define status asthmaticus. That's where a patient has life-threatening asthma, meaning they're hypoxic, they're respiratory distress, and we're treating them. We're giving them the albuterol, the steroids, all that, and it's just not working. That's called status asthmaticus, which is a life-threatening issue that must be dealt with very aggressively. Asthma exacerbation is often caused by a trigger. As I mentioned, that part of your job as a nurse is to educate the patient to determine what that trigger is and to avoid it. COPD is very closely related to asthma. COPD, depending what textbook you look at, is either a combination of 2 or 3 diseases. If it's 2 diseases, it's emphysema and chronic bronchitis. If it's 3 diseases, it includes the asthma that we just talked about. Chronic bronchitis is inflammation and excess mucus in the bronchial tubes. Emphysema is damage to the alveoli. Alveoli, you'll remember, are the tiny little sacs, the grape clusters that are at the very edge of your lungs. Very edge meaning when air comes into the body, the farthest point into my body it gets is into the alveoli. And at the edge of the alveoli, if this is my one little alveoli, the edge of it is surrounded by blood vessels. And when air comes into the alveoli, it crosses into that capillary, that blood vessel. So that's how oxygen actually makes it into the blood system. And that's where it hops on a hemoglobin and gets distributed throughout the body. So emphysema is where those alveoli get damaged, which obviously can massively negatively affect our entire respiratory system. The presentation of COPD is wheezing and or rales, accessory muscle use, and a cough. Now, a few specific things. Barrel chest is something you'll see in your textbooks, is a symptom or is a sign of emphysema, and clubbed fingers is a sign of chronic bronchitis. Just some specific signs there. I did see this in quite a few test banks, so you should definitely know that. But generally, the symptoms are going to be wheezing, accessory muscle use, that they have to actually put more effort into breathing, and that they have a cough. This is diagnosed, again, the exact same thing as earlier with history, physical exam, and spirometry. The management of this patient, they're going to get oxygen, and this is the patients that you see with at-home oxygen. Almost all of them, it's because of this. It's because of COPD. Again, they're going to get the same asthma treatment, the bronchodilators, the steroids. We're going to teach them breathing techniques. This is where very commonly the patients do that pursed lip breathing. If you remember, that was where they're slowly blowing it out like a straw, which keeps the lungs inflated longer, because again, it's a problem with the alveoli, which is where when the lungs are maximally inflated. So what we can keep the lungs fully inflated, keep those alveoli inflated, it'll help the patient out. Nearly all patients with emphysema do have a history of cigarette smoking, and this is where hypoxic drive could be a concern. Let me explain that. This patient has a problem getting rid of CO2. We learned about 20 minutes ago that all patients, all healthy people, when we breathe, our breath is stimulated by an excess of CO2. These patients always have an excess of CO2, so the body eventually realizes this isn't working. We can't just be breathing all the time because we have a high CO2 level. So the body says, let's switch to hypoxic drive and let's just breathe when we have a low O2 level. So they can end up with hypoxic drive. And the concern there is if they're only stimulated to breathe when they have a low oxygen level, in theory, when the patient gets a very high oxygen level, they stop breathing. Next, we have pneumonia. There's a lot more to get into that. I'm going to leave it there for now. Next, we have pneumonia. Let's talk about that for a few minutes. Pneumonia is a bacterial infection of one or more lobes of the lungs. This presents with tachycardia. It's an infection, so you'd have tachycardia. You'd have a high white blood cell count. The area of the lungs that has an infection would have adventitious sounds, such as rhonchi, over those areas. You would have a productive cough because the body is trying to get rid of the excess secretions and garbage that comes with having an infection. Obviously, it is an infection, so you'd have fever. You'd have the patient breathing quicker because of the fever, and you'd also have fatigue because the body has a full-blown immune response. The diagnosis of pneumonia is made based on consolidation on the chest x-ray. So a simple chest x-ray does diagnose pneumonia. It doesn't require a CT. There are three variations of pneumonia. CAP or CAP is community-acquired pneumonia. That's what a non-hospitalized patient, anyone who's walking into a clinic, urgent care, ER, and has pneumonia, that's called CAP. HAP or healthcare-acquired pneumonia is, and I put here, I see hospital-acquired pneumonia. Most of the books do say healthcare-acquired pneumonia, and that's where a patient's been in the healthcare system, either as a resident in a nursing home or in an assisted living, or if they are actually a hospitalized patient. Any of those cases, if they develop pneumonia after being in there for more than 48 hours, that's called healthcare-acquired pneumonia. And then we have ventilator-associated pneumonia. We talked about this earlier with mechanical ventilation. How do we treat pneumonia? This is treated with antibiotics. It's a bacterial infection, so they do need antibiotics. The typical antibiotic, you don't need to know this, I wouldn't imagine, for your class, but just FYI, usually doxycycline or augmentin are the two most commonly used oral antibiotics for a typical at-home pneumonia, community-acquired pneumonia. For patients that do have pneumonia, we encourage them to cough to help get rid of that junk out of the lungs. We encourage them to do deep breathing, and we also encourage them to take over-the-counter medication for symptom relief, whether that's pain or coughing or whatever it is. We also obviously encourage vaccination for the prevention of pneumonia. Plus, I do want to point out, we encourage vaccination of the flu for prevention of pneumonia because the flu is one of the most common causes of a patient developing pneumonia. In fact, that's one of the big things we look for when a patient comes into urgent care or some other healthcare setting where they've had the flu for a while and it's been getting worse, is that the first thing that we're concerned about is that it turned into pneumonia. Next, we have bronchitis. This is inflammation of the bronchi, very simple, bronchitis, inflammation of the bronchi. Almost always this is due to viral infection. Stereotypically, this follows an upper respiratory infection where the patient had a common cold and it lasted for a few days, but now this cough has been here for 2 weeks since then, and that would be bronchitis. Presentation is primarily a cough. It's diagnosed based on what the patient reports and the findings of the provider, and it's managed with supportive care, plus they take over-the-counter medication for symptom relief. Most commonly, the current guidelines recommend these patients take a combination of Mucinex and Delsum, but I'm not going to use brand names. So actually, we're talking about dextromethorphan and guaifenesin, that the patient takes both of these together, and that helps suppress their cough until the bronchitis clears up. It usually lasts 2 to 3 weeks. I've seen some bad seasons where it's lasted even longer, but that's what bronchitis is. Next, we have influenza. The pathophysiology over here is that it's a viral infection caused by inflammation and destruction of the respiratory epithelium. So this is influenza. This is the flu that we're very familiar with. COVID-19 is a version of the influenza. The presentation is fever, chills, runny nose, cough, sore throat, aches, fatigue, some or all of those. This is diagnosed stereotypically with nasal or throat swab testing, which is available, very widely available. And this is managed with supportive measures. We don't really give any prescription medications for it. There is a medication for this. It's called oseltamivir, if your course tests you on that. But oseltamivir is not given very often. It can only be given within 48 hours of symptoms. So it has to be within, if they came to the doctor within 48 hours of the flu starting, otherwise it doesn't really work. And even in that case, the studies show that it usually it shortens the duration of your symptoms by about 1 day. So patients that get it versus patients that don't get it, they'll maybe be better 1 day sooner. So no massive upside to it, but that is the prescription option available. Otherwise, we do manage them with over-the-counter medication for symptom relief, just like we said for the last few of them. Plus, we do work very hard on disease transmission. For nurses, we do require droplet precautions. Again, even though that might not be practiced all the time, that's certainly going to be fair game for your nursing exam and for the NCLEX. We certainly recommend that all patients get the flu vaccine every single year in order to maintain or in order to prevent getting something that there's no reason they should get if they get the vaccine. COVID-19 is a subset of influenza. It's one strain of it. I think the whole world by now knows that. And this one is all the same, except that the symptoms over here can include the loss of taste or smell. And I am starting to see this on test banks, all the ones that have been newly updated since COVID. So that's COVID-19. Next, we have pulmonary embolism. For pulmonary embolism, the pathophysiology is a blood clot in the pulmonary artery leading to impaired gas exchange. So remember, when we bring air into our lungs, it makes it all the way down to the alveoli, and then it crosses from the alveoli into the capillary. And from the capillary, now it's in the bloodstream, and now it keeps going. Except if there's a blood clot in that bloodstream, then it crossed over to there, but it's not going anywhere. It's stuck. So that leads to impaired gas exchange. The presentation is sudden onset chest pain, hypoxia, tachypnea, and tachycardia. The diagnostics for this would be an ABG because it's a respiratory issue. We would probably do a D-dimer if we're really worried acutely. We would just send them straight for a CT to find out right away if there's a blood clot there or not. The management of this patient is going to be oxygen and anticoagulant. It's a clot, so it has to be treated with an anticoagulant. And there's a whole lot to know about that you'll learn if you take pharmacology. These patients can be really critical. Patients can die from a PE. There's something called a saddle embolism. There's a whole lot that goes into this. I'm not going to go deep into this in this lecture, but there's a lot to know that these patients should be considered critical. Next, we have a pleural effusion. This is a fluid buildup in the pleural space. So we already talked about that pleural space a whole bunch, but let's talk about it one more time. This is where fluid builds up. It could be fluid from an infection. It could be fluid. It could be cancer. It could be from trauma, from blood, different things. The presentation, again, is sharp pain when they breathe in, and they could have decreased breath sounds over that area because there's no air movement in that area. There's just fluid sitting there. And obviously, they could have respiratory distress and dyspnea. This is diagnosed by imaging, either chest x-ray or a CT or ultrasound. All of those are valid methods of determining if a patient has a pleural effusion, depending on what is going on in the ER, what their specialty is, how proficient their providers are at ultrasound, or different things, depending what modality they're going to use. The management of this is going to be to encourage deep breathing, to position the patient in high Fowlers, and to do that thoracentesis that we talked about earlier, which is draining fluid out of the pleural space. They might also need a chest tube if it's really bad to get that fluid out. Plus, whatever caused this, whether it's trauma, whether it's cancer, an infection, whatever caused this, we do need to treat that as well. We can't just treat this complication, the pleural effusion. We have to treat what actually caused it. An empyema is a type of a pleural effusion. It's an infectious buildup of fluid in the pleural space. Again, the pleural effusion we said is just a buildup of fluid. If it's a infectious fluid, that would be called an empyema. Let's talk about tuberculosis. Fun fact, this is the most prevalent bacterial infection in humans in the entire planet, that more people have tuberculosis than any other bacterial infection. The pathophysiology, it's a slow onset bacterial infection that's most common in the upper lobes of the lung. The presentation is a slow onset presentation. We'll have weight loss, night sweats, persistent cough, not usually, but very often with blood, which is called hemoptysis, and a low-grade fever. This is diagnosed with a chest x-ray, and most of you in healthcare or nursing school are probably familiar with this because we do also test for this in healthcare providers on a regular basis, either through a TB skin test or nowadays more commonly through a quantiferon blood test. But a chest x-ray would absolutely be the great way to find out if they have it or not. If a patient does have tuberculosis, in addition to being placed on droplet precautions for this, one more time, airborne precautions, because this disease is transmitted airborne. This is where the nurse would need to wear an N95 mask. This is where the patient needs to be isolated in a negative pressure room. This is a reportable disease, so it does need to be notified to the local health department. And there is a vaccine available for this. How do we treat this? We treat this pharmacologically, and it is very treatable as long as the medications are available, which fortunately in the United States, that's not an issue. The medications we use are isoniazid, rifampin, pyrazidamide, and ethambutol. These do spell out the acronym RIPE, R-I-P-E, rifampin, isoniazid, pyrazidamide, and ethambutol. Two of these medications are also used for the prevention of tuberculosis in healthcare providers that were exposed. So if you had a patient that you treated for TB, that was diagnosed with TB and you didn't know that at the time and you came in close contact with them, you may get put on post-exposure prophylactic medication, which is where even though you're not sick yet, because you were exposed to a TB patient, we may put you on isoniazid and rifampin temporarily, usually for about 2 months until we're confident that you're not going to get that infection. Next, we have ARDS. Before we go any further, ARDS is a secondary complication. No one walks into the ER and is diagnosed with ARDS unless they've been super critically ill for a long time. ARDS is where a patient has severe pneumonia or some other disease that causes a complete meltdown of the rest of the lungs. So what's the pathophysiology? The alveolar capillary membrane, remember we said oxygen is always crossing that membrane, oxygen and CO2. When that membrane gets damaged, and now we have a whole collapse in the system. Now we have that alveoli filling with blood because the capillary is leaking blood into the alveoli. The alveoli themselves collapse and cause edema and build up a fluid and other garbage in the lungs. It's a really, really bad diagnosis to have. The presentation is going to be hypoxemia, meaning a really low oxygen level in the blood, tachypnea, breathing quickly because the oxygen level is so low, the body's doing whatever it can to compensate for that, dyspnea because they're having trouble breathing, cyanosis because they can't possibly get enough oxygen to their body because their lungs are shot to whatever, and signs of shock because this can cause tremendous problems down the line. Meaning in other body systems. This is diagnosed by their overall hemodynamic and respiratory status. There are official criteria and algorithm for how we diagnose this. I'm definitely not teaching that at the RN level, but it does involve labs, imaging, vitals, how they're progressing, and what else is going on with the patient. Again, this is always going to be a secondary complication to their primary insult being whatever it was. It could be trauma, it could be pneumonia, it could be a bunch of different things. How do we manage this? We mechanically ventilate them. These patients are very difficult to oxygenate, and there's entire classes on how to oxygenate an ARDS patient. That's way beyond this video. And we're also going to maintain hemodynamic support because they're going to have issues with that as well. Moving on from one of the most complicated things to one of the most benign things. Let's talk about upper respiratory infection. This is a URI, also known as a common cold or a rhinovirus. The pathophysiology here is a viral infection of the upper respiratory, such as the nose, the sinuses, the pharynx, or the larynx. The presentation here is going to be nasal congestion, rhinorrhea, sore throat, a cough, a low-grade fever, headache, and mild fatigue. Again, this is also infectious, so you do need to ensure infection prevention. This is diagnosed based on the presentation and what the provider assesses. The management for this is supportive care and over-the-counter medications for their comfort. We do make sure that we equip the patient with means of preventing disease transmission, such as education on staying home from school or work and getting notes if needed. RSV is a subset of URI. So let's talk about that for a second. RSV is an infection that presents as a URI in adults, and that's relatively benign. However, in children or other compromised patients, RSV presents as a lower respiratory infection instead of a URI, and in those patients, it can be very detrimental, and we treat it very aggressively. Most of you are probably familiar with that pediatric ICUs often have patients that have RSV. That is our first Med-Surg lecture. Please subscribe to our channel. Please let us know if you have any comments for how to improve the upcoming Med-Surg videos. If you have any questions, let us know. Have a great rest of the day. Here are your references.